Friends, I am going to talk to you today on injuries of the forearm, fractures, and there are some dislocations near the elbow, and as well as there are some types of combination of a dislocation with a fracture from elbow downwards. So, since I have finished lot of things in my previous class in which I have given all the details regarding different types of fractures around the elbow, this is going to be a combination in the sense there is going to be a radio-humeral dislocation, and then along with that there is going to be a proximal ulnar fracture. So, this condition is known as Monteggia fracture dislocation. Here, as I already said, if you take the head of the radius, this gets dislocated. So, this will be from the radio-humeral joint, the head of the radius gets dislocated either to the front or to the back, that is anterior or posterior. Along with this, the ulna will be in its position with a fracture in the upper one third. That is why whenever we talk about taking X-rays as a dictum, we must always include a joint above and a joint below, because we might miss some of the fractures like this. Here the head of the radius gets displaced from the radio-humeral mechanism and as well as the fracture of the proximal ulna. This is more common in children and sometimes in adults also. In this, there are two types of Monteggia fracture dislocation. One is extension type, where patient as he falls, the head of the radius goes backwards. Fracture of the ulna is common, but in extension type, radial displacement will be anterior. This is extension type. Monteggia fracture dislocation is extension type, in which there is a radial displacement will be anterior, whereas in flexion type it is opposite. Instead of being anterior, head of the radius will get dislocated backwards or posteriorly. This is a very important thing, because at the time of immobilization there are certain principles to be followed. If it is a extension type of displacement, then you have got to put it in flexion. A small tip here, very often lot of people get confused for this extension and flexion type. This is opposite to the supracondylar fracture in extension. Normally two things can happen due to fall on outstretched hand around the elbow. One is supracondylar fracture. In extension type, as the patient falls forwards, the proximal fragment will be moving forwards and the distal fragments will be displaced backwards. That is in supracondylar fracture. Right opposite to that is the Monteggia fracture. So, for the people, because we more often see a supracondylar fracture in extension where the displacement of the lower fragment is always posteriorly or backwards. If you remember this, because we see this more often, it is just opposite to that in the case of Monteggia fracture dislocation. Because as a student I used to get confused very often how to remember. As I go on analyzing, as I was trying to teach, I realized that this is the way you best remember flexion and extension type. So, having said this as an introduction, then we will go to actually what happens in Monteggia fracture dislocation. In Monteggia fracture dislocation, I already mentioned that the commonest type of violence is in extension, and following this history of falling on outstretched hand, the child will come with, the first thing is of course the pain, and the elbow looks broadened because the humerus is here, radius gone out like this. Because of this, the entire elbow area looks little broadened, and there is a prominence on the outer aspects of the elbow because of the head of the radius getting as if it protruded from its joint, and of course a little below also, as I already mentioned, here there is a fracture of the proximal third of the ulna. So, over the ulna sometimes you may even see the displacement if you just put your hand or run the finger along the shaft of the ulna, and of course there is tenderness in the upper one third of the shaft of the ulna. So, sometimes if you take an X-ray of the elbow, you are likely to miss this part of it. Elbow will show you all recurrent in its normal position, but the head of the radius is dislocated or displaced. So, whenever you have a situation where isolated head of the radius slipping, you have got to, if you have taken X-ray of the elbow and not seen anything, please don't hesitate to repeat the X-ray, ask the radiologist to show the forearm also. So this is the dictum whenever there is an isolated dislocation of the head of the radius. And sometimes what happens, people feel the tenderness over the ulna, they forget to include this part, they won't take it. You see only fracture of the ulna, and very often it may not be displaced also. So just apply a plaster of Paris like this and leave it like that, saying it's an undisplaced fracture of the ulna. So that's why you've got to be doubly careful whenever you are dealing with isolated fracture of proximal ulna or isolated displacement of the head of the radius or dislocation of the head of the radius, because quite often we see these mistakes being committed where they take only the elbow, forgetting about the forearm, or vice versa. This has been recognized by Monteggia. Naturally, the fracture is known or named after him, Monteggia fracture dislocation. So going back again, what happens following the fallen outstretched hand? Pain, swelling or broadening of the elbow, tenderness or the proximal ulna, and then inability to flex or extend the elbow. Then pronation and supination are also restricted. With these conditions, you suspect this fracture, and then not difficult to make out on X-rays. So, but be careful in asking for the proper X-ray. Then what is the treatment for this fracture? Treatment is mainly conservative, rarely surgery is needed for this Monteggia fracture dislocation. But sometimes even the head of the radius may get fractured, and of course that's a different kind of a, it won't come under Monteggia fracture, but both head of the radius fracture along with the upper end of the ulna, there will be a fracture. So for that the treatment is always surgery. Whereas here, when there is no fracture of the head of the radius, only displacement of the head of the radius with ulna, treatment is conservative. Here, under anesthesia, general anesthesia, or if you have got an expert anesthetist, you can even give a block. There are different types of blocks are there, like axillary block or scalene block or axillary block. So any of these things can be used, and then or under general anesthesia we can reduce the fracture. Very easily it comes into position, and usually it is not necessary to fix these fractures. Just apply the plaster of Paris. Apply plaster of Paris from above the elbow. So from the middle of the arm up to the knuckles, you can apply the plaster. Once again here, as we recollect, we have been talking about extension fracture and flexion fracture. If it is extension type of fracture, you will keep it in this position. Suppose it is a flexion type of fracture, immobilize the elbow in extension. This is the difference between the two types of fractures, and usually 6 weeks of immobilization. And of course, there is always the treatment where the patient does not want a plaster of Paris, or he wants to go back to the work as early as possible. Then of course, after reduction, we can fix the proximal third fracture. There is a fracture here. We can fix it up with any intramedullary device or a special type of plate like this, and this is there, but rarely we do this. In case of fracture olecranon, because along with the head of the radius, now it comes back into position. The head of the radius comes back into position. After manipulation, we can fix the fracture of the ulna by using a big plate or intramedullary device, whatever is available with you and whatever you are familiar with, you can use this. But usually it is not needed to do this.